Assalamualaikum and good day. My name is Dr. Setia Matul Sahab, ENT surgeon from Hospital Pakar Sultanah Fatimah Muar. Today I'm representing GSK to present the art and science of treating allergic rhinitis. This presentation will contain promotional content, product by GSK. In today's presentation, I'll be explaining on what is allergic rhinitis, the management, the approach in treating allergic rhinitis, and we will also discuss the differences of intranasal corticosteroid that we have in the market. So what is allergic rhinitis? It is defined as IgE-mediated inflammation of the mucosal lining in the nose and also paranasal sinuses after being exposed to an allergen. It is characterized by a triad of symptoms, namely rhinorrhea, nasal itchiness, and also sneezing. They may also have nasal congestion. There are also patients that experience allergic conjunctivitis, where they have itchiness of the eye, watery eyes, and also eye redness. Allergic rhinitis has impact on patients' quality of life in both adults and children if it remains uncontrolled. Many people with allergic rhinitis do not seek medical advice regarding treatment. Instead, they self-treat with home remedies and also over-the-counter medications. This may be because allergic rhinitis is perceived by both patients and healthcare community as less important than other airway diseases such as asthma. In Malaysia, they like to use the term sinus or rusdom. Basically, they are referring to allergic rhinitis. What are the things that can be affected if allergic rhinitis is uncontrolled? They can have problem with their sleep, decrease in the health quality, limitations in their daily activities, increase in emotional burden, and also they will have negative impact on psychosocial well-being. Moving on to the management and treatment approach of allergic rhinitis. Allergic rhinitis can be divided into perennial and also seasonal. Perennial allergic rhinitis is caused by indoor allergens like dust mites, insects like cockroaches, molds, and also pet dander. For seasonal allergic rhinitis, it is related to a wide variety of outdoor allergens such as pollens and also molds. In the area classification, allergic rhinitis can be classified as mild or moderate to severe, depending on the severity of the symptoms and their impact on social life, school, and also work. We can diagnose allergic rhinitis when they have two or more of these from these four nasal symptoms, namely nasal obstruction, itchiness, sneezing, watery rhinorrhea with or without allergic conjunctivitis. If they have two or more of the symptoms that occurs more than 1 hour on most days, we can diagnose allergic rhinitis. And from there, we need to take history, the frequency of the attacks. If it is less than 4 days per week or less than 4 weeks, it is intermittent. If it happens 4 or more days per week and 4 or more consecutive weeks, we call it persistent. So in the end, diagnosis of allergic rhinitis would be mild intermittent AR or moderate to severe persistent AR. If we were to compare differences of intranasal corticosteroid, we have to know what is intranasal corticosteroid first. So it targets the eosinophilic pathway, and it is most effective treatment for moderate to severe allergic rhinitis by improving nasal blockage, and it has a favorable safety profile. The high efficacy of intranasal corticosteroid is attributed to their ability to modulate the pathophysiology of allergic rhinitis, including release of multiple mediators and also cytokines, as well as the recruitment and infiltration of activated inflammatory cells to the nasal mucosa. Accordingly, intranasal corticosteroid are effective at attenuating both early and late symptoms, including nasal congestion and hyperresponsiveness. The onset of action may occur within 12 hours of administration, but may commence as early as 3 to 4 hours after use, which is slower than the onset of antihistamine. continuous daily use of intranasal corticosteroid may be needed in order to achieve maximum efficacy. Although as needed intranasal corticosteroid dosing is less effective than continuous dosing, it may be an appropriate option for some patients with intermittent symptoms. Most of the guidelines suggested intranasal corticosteroid as the first line for moderate to severe persistent allergic rhinitis. Assessment of control in symptomatic patient based on ARIA 2020. If it is an untreated allergic rhinitis, if VAS score less than 5, you can start the first line medication, antihistamine, intranasal corticosteroid, and even combination of intranasal corticosteroid with azilastine. If VAS 5 or more, the treatment would include the first line medication for intermittent, or if it is persistent, we can straight away start them with intranasal corticosteroid or intranasal corticosteroid with azilastine. If it is not controlled with this medication, you may consider giving them immunotherapy. In cases of treated allergic rhinitis, if VAS score less than 5, usually they will be already on this first line treatment. If they have intermittent symptoms and no allergic exposure, we may step down the treatment or even stop the treatment, entirely stop the treatment. If they have persistent or still having allergen exposure, you can maintain the medication or you may step up treatment. If they have VAS score of 5 or more, we have to include intranasal corticosteroid or combination of intranasal corticosteroid with azilastine. If this fails to control the symptoms, we may consider immunotherapy. Moving on to the clinical efficacy of fluticasone furoate nasal spray, which is Avamis. This slide shows efficacy of fluticasone furoate on 4 nasal symptoms of allergic rhinitis, including itchiness, sneezing, congestion, and also rhinorrhea, and 3 ocular symptoms, namely eye itchiness, watery eyes, and also red eye. So fluticasone furoate, it is proven to be consistent across all 7 nasal and ocular symptoms. The y-axis is the total nasal symptom score. Orange bar represents fluticasone furoate nasal spray. The grey color represents placebo. When we compare with placebo, it has a significant improvement on all 7 nasal and also ocular symptoms. This is an interesting paper as it shows the long-term efficacy of fluticasone furoate nasal spray over 2 years. So there is a question that does all intranasal corticosteroid equally consistent to improve ocular symptoms in allergic rhinitis symptoms? You can see the number right after each intranasal corticosteroid name. It's the number of randomized placebo-controlled clinical trials of intranasal steroid with ocular efficacy endpoints. The blue bar represent the clinical studies that have a positive or benefit of intranasal steroid on ocular symptoms. The red color bar represents the studies that inconclusive or had negative result on ocular symptoms. So from this figure, fluticasone furoate nasal spray had consistent efficacy on ocular symptoms, but other intranasal corticosteroids such as fluticasone propionate, budesonide, mometasone did not have consistent efficacy on ocular symptoms. Beyond the ocular symptoms, let's talk about intranasal corticosteroid and the improvement of sleep disturbances. From these 2 studies, fluticasone furoate significantly reduced nighttime sleep disturbances in seasonal allergic rhinitis patients than oral antihistamine. Parameters that they studied on are nasal congestion on awakening, nighttime awakenings due to nasal symptoms, and also difficulty sleeping due to nasal symptoms. Safety of fluticasone furoate nasal spray. This slide shows the bioavailability on different intranasal steroids, including fluticasone furoate, mometasone, and also budesonide. The studies have shown that newer generation intranasal steroids have lower systemic bioavailability, which reduces the likelihood of systemic adverse events. A 2-week US study in patients with seasonal allergic rhinitis, a 12-week global study in patients with perennial allergic rhinitis, and a 6-week US Hpsf safety study in patients with perennial allergic rhinitis. So when we talk about device and also patient preference, according to the American Academy of Otolaryngology Head and Neck Surgery, sensory attributes an important factor in patient preference and adherence to therapy when we talk about the different preparations of intranasal corticosteroid. The sensory attributes includes the presence of aftertaste, round out nose, a drip down the throat, and also smell. Patients with allergic rhinitis preferred fluticasone furoate versus mometasone overall, and based on a number of individual attributes, including less drip down the throat, less run out of the nose, and less irritating. Greater preference may improve patient adherence and thereby improve symptom management of the patient's allergic rhinitis. Patient's preference should be considered when recommending an intranasal corticosteroid product. For Avamys, it is designed to meet patients' need. It is a more patient-friendly spray because they have less aftertaste and smell, less drip down throat, nose, down the throat, and also nose. And they have a finer mist spray which delivers a consistent dose each time. The nozzles are more comfortable to be used because it is short and ergonomically designed. With the side actuation, we found it is easier to grip and easier for the caretakers to administer medication. The viewing window on the bottle will let patients see how much drug is left, therefore will prevent wastage of unused medication. So in summary, allergic rhinitis is a common chronic condition which characterized by IgE-mediated inflammation of the nasal mucosa, characterized by triad of symptoms which are sneezing, itchiness, and also runny nose. Poorly managed allergic rhinitis will have a huge impact on patients' quality of life, especially they can have disturbed sleep. Intranasal corticosteroid is the first line treatment option in cases of moderate to severe allergic rhinitis, especially when they complain of blockage or nasal congestion. Understanding the preference are the key important factors to consider in ensuring successful allergic rhinitis management and also patients' adherence to the medication. In order for us to prescribe Avamys for adults and adolescents aged more than 12-year-old, the recommended starting dosage is 2 sprays in each nostril once daily, which come to a total daily dose of 110 microgram. For children aged 2 to 11 years, the recommended starting dose is 1 spray in each nostril once daily, total daily dose of 55 microgram. So currently, Avamys is the only nasal spray that has no generics, and I understand that it is under the quota system that is available for 600 patients. So in the end, why intranasal corticosteroid? It helps to target eosinophilic pathway. It is the most effective treatment for moderate to severe allergic rhinitis. It helps to improve nasal blockage, and it has a favorable safety profile with low systemic effects. who to be given intranasal corticosteroid when patient does not respond to oral antihistamine, when they have main complaint of the chief complaint is nasal blockage, patients with moderate to severe allergic rhinitis that affects their quality of life. When to give? It is possible during is it possible during visit time or only during free time? We can advise them to take the medication early in the morning, because majority of the patient will have symptoms in the morning. How long do we need to give this medication? At least 2 weeks. Review again, then can continue for another 2 weeks. If the patient symptoms control with the medication, you can just continue with Abamis. And remember to prime the device first before using. So with that, I